Hello, everyone, and welcome to the fifth webinar of our educational series of CLL Care, Comprehensive Advance in Patient Care. And today, we have with us Dr. Andrea Visentin. He is an assistant professor at the Department of Medicine at the Unit of Hematology and Clinical Immunology at the University of Padova in Italy. And his research has significantly contributed to understanding the mechanism of disease progression and treatment resistance in chronic lymphocytic leukemia. He has also authored and co-authored numerous peer-reviewed articles in different journals, and he's also actively involved in teaching and supervising medical students and young researchers, inspiring the next generations of hematologists. And today, he is joining us to explore the world of CLL, more specifically, how to manage high-risk and relapsed refractory CLL. One more thing before we start, I just want to remind you some house rules. You will be muted for the entire duration of the webinar, but you can always ask questions using the chat box that we will read and discuss at the end of the webinar. So, Dr. Andrea, thank you again very much for joining us, and please feel free to start whenever you're ready.
Good morning to everyone. Thank you, Bianca, for your warm introduction, and thank you, MFAR, for the kind invitations. Okay. Today we will define first which is the definition of high-risk patient, biologically high-risk patients, and then we will discuss which is the optimal sequencing and how is the first line choice influence the choice of further lines of therapy. During the 2024, many guidelines have been recently updated. As you can see, the European guideline, the NCCN guideline, the NCH, and recent guidelines which has been published by important co-authors in Blood Cancer Journal during the early of 2024. But start with the first part of the talk. Which are the patient classified as high risk? We know that the worst prognostic factor, as in CLL, but also in many cancers, is the presence of aberration of TP53 gene, including deletions of the genes as assessed by interphases FISH, but also the mutation of the gene assessed by single sequencing of next generation sequencing. Here you can see the late breaking abstract presented by the German study group during the last year meeting. They were able to pull together about 10,000 patients studied for the presence of TP53 mutation. And as you can see in the Kaplan-Meier on the right, after a median follow-up of 65 months, overall, the presence of TP53 mutation was associated with shorter progression-free survival and overall survival. Of course, the presence of mutation have a negative impact in patients treated frontline with chemotherapy, but also in patients treated with targeted agents. Focusing on a small group of 60 patients who received a ibrutinib-based time-limited therapy, TP53 mutation was not associated with impaired progression-free survival, but there was a trend for a shorter overall survival. We know that the presence of big or a high burden of mutation is, of course, which can be detected with single sequencing as a negative impact, but also low burden small clones harboring TP53 mutation, which cannot be detected by single sequencing, but it can with next generation sequencing. These small clones, a low burden of TP53 mutation is also associated with a negative impact in patients with chronic lymphocytic leukemia. So the recently updated ERIC guidelines regarding this topic suggest and reinforce the notion that the TP53 mutations and TP53 and 7TP deletions must be assessed in all patients who need any treatment, either the first line, but it must be also reassessed in every time the patient need a treatment, because they can acquire this mutation even after the use of targeted agents. We know that this patient cannot be treated, must not be treated with chemoimmunotherapy because they are chemorefractory, and we have to opt for a targeted agents. And another point that the new guidelines suggest that it should be better to use the next generation sequencing in order to identify small clones, and this small clone must be reported in the report. And well, if not available, okay, we can opt for the Sandwich sequencing, studying exons from exon 2 to exon number 11. The ESMO guidelines didn't mention about cytogenetic abnormalities apart from 70p deletions, but the recently published guidelines from the German study group include the assessment of with stimulated karyotype. The same did the NCCN guideline. Because the stimulated karyotype allowed to identify the presence of complex karyotype that is defined by the presence of at least 3 cytogenetic abnormalities. And an important ERIC study and also the German study group demonstrated that the patient with at least 5 cytogenetic abnormalities had the worst outcome indeed. And as you can see in this Kaplan-Meier, a patient with complex karyotype, at least 3 or more than 5, they have, in fact, indeed, the worst overall survival. And this is true also for patients treated with in this table on the left, and but also in this Kaplan-Meier on the right. As you can see, that patient treated with ibrutinib with more than 5 cytogenetic abnormalities had a shorter overall survival as compared to patient with a lower number of cytogenetic abnormalities. And also in a pooled sub-analysis from the CLL 13 trial, which explored the role of fixed duration of venetoclax based therapy, you can see that the patient with more than 5 cytogenetic abnormality had a shorter progression-free survival as compared to the other cytogenetic group. So maybe complex karyotype should also be assessed in every patient. And in a couple of weeks, we will see this oral presentation at ASH, which was a study done by the colleague from Boston, from the Dana-Farber Cancer Centers, and they were able to demonstrate that the complex karyotype, but not the TP53 mutation, was associated with a short overall survival in patients with chronic lymphocytic leukemia treated with targeted agents. So when complex karyotype was included in the multivariate analysis, the predictive value of TP53 was lost. And of course, it was significantly associated with a shorter overall survival. So the assessment of complex karyotype is, of course, important in our patients. As you know, the guidelines rarely give a strong recommendation about which drug to use in the specific kind of patient. Instead, they provide a list of all the available drugs. They only, of course, they reinforce the notion that we should not use chemoimmunotherapy for the first line or further lines of therapy, apart from Richter transformations. And when we are managing a patient with TP53 abnormalities, we should use a continuous treatment using a covalent BTK inhibitor. This is based on the result and the sustained remission with continuous covalent BTK inhibitor, ibrutinib, acalabrutinib, or zanubrutinib. But they also allow for the use of time-limited treatment. This is based on the result of the CLL14 trial and the Captivate trial, which included also patients with high-risk features. As you can see in the sub-analysis from the CLL14 trial, the median progression-free survival for patients treated with frontline venetoclax obinutuzumab is about 48 months. Instead, in a young patient treated with the combination of ibrutinib plus venetoclax, the median progression-free survival is 60 months, which means 15 months of therapy and 45 months of drug holiday, which means about 3 to 3.5 or 4 years of drug holiday till the second line of therapy. So we are not dealing with 8 to 10 months that we use with chemomonotherapy in this aggressive subset. We are talking about some years, and the drug holiday period is of course important for our patients. Then when we have to, if the patient relapses or when he relapses, we have the available drugs are of course the same. So we have the group of covalent BTK inhibitor, or we can use venetoclax plus rituximab, 24 months of treatment based on the result of the Murano trials. Other options are, of course, chemomonotherapy, PI3 kinase inhibitor, in particular idelalisib, the only approved in Europe, but it is rarely used given the high rate of adverse events. Then there are the option of allogeneic stem cell transplantations or CAR T cells, and also novel drugs such as the non-covalent BTK inhibitor pirtobrutinib, which is recently approved by FDA, or the use of bispecific antibody. When we have to choose the first line of therapy, we have to take into considerations different aspects. The first of all is that there is always a better options than chemomonotherapy for relapsed refractory CLL. This is based on the result of the Murano trial, which compared 24 months of venetoclax plus rituximab versus bendamustine rituximab. These are the long-term follow-up of the Murano trial, and you can see that patients with venetoclax plus rituximab have an improvement in the overall survival. Then there are the results from the ASCENT trial, which compare continuous acalabrutinib versus the investigator choice between bendamustine rituximab or idelalisib rituximab. Of course, there is an improvement in progression-free survival with continuous acala, and there is a trend for a better overall survival with acala as compared to bendamustine rituximab. And again, at ASH 2024, the result of the BRUIN CLL 321 trial will be presented, which is an international phase 3 trial which compare pirtobrutinib in relapsed refractory CLL compared to the investigator choice of bendamustine or idelalisib plus rituximab. Although the follow-up was short, about only 11.6 months, the pirtobrutinib was able to demonstrate, to provide evidence for a better progression-free survival in overall, but also in the group of patients previously treated with venetoclax-based therapy, and also in aggressive subset of patients with complex karyotype or TP53 abnormality. So another bullet to use to fight against this disease. As I said before, when we have to face a relapsed refractory patient, we have to take a lot of consideration. First of all, is if the patient received as a targeted agent or chemotherapy as a first line, we have to consider the durations of the first remission if we receive a time-limited therapy. But we also have to consider many other things, such as the patient comorbidities, the concomitant medications, the preference of the patients, the duration of second or further lines of therapy, the way it is administered, if he had to take the pills at home, or maybe if he need a caregiver to bring him to the hospital, which might be the compliance of the patient and the complexity of the clinical trial he needs. Of course, the pro and contra of continuous treatment with a covalent BTK inhibitor, a time-limited venetoclax-based therapy are, of course, the same as in the first-line settings. From continuous treatment, they are, of course, tablets or pills, but the patient needs to take it for a very long time, and so the risk to experience an adverse event is higher. From the other part, the time-limited treatment is of course about 12, 15, or 24 months regarding the regimens, but also it usually use a combination of two drugs, usually one oral drugs or an intravenous drugs. So the patient has to come to the hospitals. During the ramp-up phase of the venetoclax, we have to manage the risk of tumor lysis syndrome. So the patient needs some control in the morning and in the afternoon. And of course, he need maybe most of the time they need a caregiver for the management of the patient, in particular during the first weeks of the treatment. During a recent survey about patient, of course, patient would opt for a treatment that provide a better progression-free survival, but given an equal efficacy, the patient would prefer a fixed duration over continuous treatment. Instead, from the point of view of oncologist or an hematologist, for some kind of patient, in particular for high-risk patient with a relapsed refractory disease, the oncologist or the hematologist would opt for a continuous treatment in order to better control the disease. And also there are other 2 points that favor might help in guiding the treatment. The one is the cost. Of course, the cost of a continuous treatment is higher, but if we take into consideration only the first year of treatment, the first or the second year of treatment, the use of combination time-limited therapies, the cost of these drugs are higher than a continuous treatment with a single agents. And last but not least, the use of a continuous therapy can increase the risk to develop of BTK mutations. These are the flow chart of the published ESMO guidelines regarding relapsed refractory patient. And as I said, when we are dealing with this kind of patient, we have to take into consideration the type of the first-line therapy, the duration of the remission, and the risk of acquired resistance to a treatment. And for example, if the patient is naive to both covalent BTK inhibitor and the BCL2 inhibitor, we can opt for a continuous therapy with a BTK, second generation BTK inhibitor, because there are published data from the head-to-head comparison of first generation ibrutinib versus the second generations acalabrutinib, the ELEVATE-RR trial, but also of ibrutinib versus zanubrutinib, the ALPINE trial, and both studies demonstrated that these drugs are better, second generation BTK inhibitor are better tolerated than ibrutinib, and the ALPINE study were able to demonstrate a higher efficacy of zanubrutinib as compared to ibrutinib. The other option is of course the combination of venetoclax plus rituximab based on the result of the Murano trial. And then if a patient relapses again, we can switch the two classes, covalent and BTK inhibitor or BCL2 inhibitor. Instead, if a patient receives a first line with a covalent BTK inhibitor, if we stop treatment due to adverse event, so if he is only intolerant to first generation BTK inhibitor, we can use either acalabrutinib or zanubrutinib. There is a study with zanubrutinib that enrolled patients who discontinued therapy with ibrutinib or acalabrutinib due to adverse event, and this study demonstrated that these patients have a very low risk to experience the same adverse event that led to the discontinuation of ibrutinib and acalabrutinib. Instead, if a patient experiences a disease progression during a covalent BTK inhibitor, we can, of course, opt for a combination of venetoclax plus rituximab. The third option is if a patient receives as first line venetoclax or obinutuzumab, we can only move to a covalent BTK inhibitor, for example, zanubrutinib, but also ibrutinib. But as I said before, based on the result of the Alpine trial, I would opt for zanubrutinib. Theoretically, there is the option of retreatment with venetoclax or obinutuzumab, but up to now, there are no published available data. They will be provided by the available, no data are available. We know that in the US, some colleagues are using VG as retreatment, but we have no data. Another point of discussion is, and no one has the answer to this question, is it better to use venetoclax obinutuzumab as second-line therapy to retreat with venetoclax obinutuzumab, or is better to use 24 months of venetoclax plus rituximab? But as I said, there is no answer for these questions. The fourth option is to start the treatment with ibrutinib plus venetoclax, and after this kind of therapy, we can either use a single agent covalent BTK inhibitor. There are data from ibrutinib, but we can also think that also other second generation BTK inhibitors might be active in this setting of patients, or the use of venetoclax plus rituximab, and then if the patient relapse again, to switch this kind of drugs. And there is also the option, not still approved in several countries, the option to retreat the patient with the same combination of I plus V. Of course, after the further relapse, we have to take into consideration allogeneic stem cell transplantation for young patients, and if not feasible, as a third line, we can take into consideration the use of non-covalent BTK inhibitors and other investigational drugs such as BTK degrader, bispecific antibody, and CAR T cells. So in a scenario A, this is what we have done for many years, if we start with a covalent BTK inhibitor and then we move to venetoclax plus rituximab and then to the non-covalent BTK inhibitors, we can give this patient 3 lines of therapy. And if he is a low-risk patient, probably he will only receive 1 or 2 different lines of therapy, because we know that in low-risk patient, the median progression-free survival with first-line covalent BTK inhibitor is about 9 to 10 years, so a very long period of time. Instead, in the scenario B, with venetoclax plus obinutuzumab, then covalent BTK inhibitor, and then non-covalent BTK inhibitors, again, 3 lines of therapy. But if we start with I plus V, we can give to this patient a higher number of lines of therapy. So 1, 2, 3, and 4 lines of therapy for high-risk patient. And if the patient is lucky and if he experiences a long duration of remission, we will need to define what is a long remission after I plus V. So if for this kind of patient, we can give him 1, 2, 3, 4, 5 different lines of therapy. And if we are facing a young patient with a high risk disease, of course we have to take into considerations all the number of available drugs that I might give to him, because he has a very high risk of relapsing. So the sequencing is important. Also considering that the median progression-free survival for this high-risk patient is not short, it's about several years. And of course, the use of venetoclax plus rituximab as a second-line therapy, as we said, is based on the result of the Murano trial. But in that trial, only 2.6% of the patients receive a targeted agent as first or second line, as a previous lines of therapy. So we do not have a prospective data on the use of venetoclax plus rituximab after a covalent BTK inhibitor. There are very few data from the literature but it's not so good. It's about 20 to 24 months after a covalent BTK inhibitor, suggesting that a patient who relapses after a covalent BTK inhibitor might have a more aggressive disease as compared to patients who relapse after chemoimmunotherapy. Where we have some data about retreatment from the Captivate trial, and although the follow-up is short, and patients who were retreated in the Captivate trial were enriched for high-risk features. As you can see, about 30% of patients harboring TP53 abnormalities, and another 34% with a complex karyotype. Well, you can see that the majority of patients are still responding with a ibrutinib-based retreatment, either single agent or a retreatment with ibrutinib plus venetoclax. So retreatment is feasible after I plus V. For the majority of cases, the best third line of therapy is the non-covalent BTK inhibitor pirtobrutinib, which has recently been approved by FDA for the treatment of double refractory patients. Pirtobrutinib is a highly selective BTK inhibitor, which allowed plasma concentration always above the IC50 of the molecule. And also, pirtobrutinib is able to inhibit the kinase, but also to stabilize BTK in a close inactive configuration. So BTK is not able to act as a docking site to promote the B-cell receptor signaling. The result of the pirtobrutinib has been published in New England Journal of Medicine in 2023 in the phase 1/2 trial of the BRUIN trial, which involved 317 patients who received pirtobrutinib. 2,047 have been previously treated with BTK inhibitors. The median number of previous therapy was 3, and as you can see, after the median follow-up of almost 2 years, the overall response rate was 73%, including 70% in patients who were double refractory, and the median progression-free survival is about 19.6 months. The treatment was very well tolerated, and as you can see, the percentage of patients experience grade 3 or higher adverse event is pretty low. The higher is about the cytopenia. We know we are facing a very heavily treated populations, so it's not uncommon. And the same is for infection. As you can see, 28% of patients experience a grade 3 infections. Instead, the BTK-related adverse event was quite rare in this population, as it is for atrial fibrillation, hypertension, and bleedings. The study was updated during the last ASH. This was the presentation by Jennifer Boyack from the Ohio State University. Patient who received a prior covalent BTK inhibitor were 282, and they were split about the previous exposure to venetoclax or not. The median number of previous therapy was 4, so a very heavily treated population. All of them received a covalent BTK inhibitor, and about half of them also a venetoclax treatment. And a large number of these patients also harbored high-risk features and BTK or PLC2 gamma mutations. As you can see, after median follow-ups of almost 30 months, the progression-free survival was longer for patients who were naive to venetoclax-based therapy as compared to double refractory patients, either in terms of progression-free survival and also in of overall survival. So this raises the question if pirtobrutinib should be moved before venetoclax, or as we do in this months to use pirtobrutinib only in double refractory patients. The other thing that I want to discuss to you is that patients with high-risk patients, as those with TP53 abnormalities or complex karyotypes, they have a higher risk to relapse after also targeted agents, but also if they are treated with a continuous therapy, they harbor a higher risk to relapse and to acquire BTK mutations. We know the majority of this study have been explored with the use of ibrutinib. There are small studies assessing the role, the incidence of BTK mutation after second generation BTK inhibitors. Here I present you this is this picture from the sub-analysis of the ELEVATE-RR trials, which analyzed the presence of mutation in patients who relapse after acalabrutinib or after ibrutinib. The study demonstrated that a higher rate of BTK mutation patients who relapse after acalabrutinib, 66% versus 37%. The majority had the classical cysteine 481 mutation, but there was also a higher number of patients who acquired the gatekeeper mutations, that is the threonine 474 mutations. So the type of BTK inhibitor we use might be associated with different BTK mutations at relapse, and this might be important for the further treatment because currently we don't know exactly how to manage a patient with BTK mutations. One option might be to use a venetoclax-based therapy. In this experience from the colleague from Hungary, they demonstrated that when we start treatment with venetoclax, we are able to drop the variable frequencies of BTK mutation. But as you can see in these examples, when the patient relapse, they still have the BTK mutation. So venetoclax is not able to eliminate the clones harboring the BTK mutations. The other options is to use pirtobrutinib, as I said. Also, in vitro study demonstrated that pirtobrutinib is able to inhibit the kinase harboring the cysteine 481 mutation, that is the classical mutations. And in this study presented at ASH, who analyzed the presence of mutation in patients who relapse after pirtobrutinib, also demonstrated that pirtobrutinib is able to clear the clone harboring the cysteine 481 mutations, but according to the the majority of clones who at relapse harbored different kind of mutations, such as the gatekeeper mutation, threonine 474, or the kinase dead mutation, leucine 528 tryptophan mutations. So suggesting that pirtobrutinib is able to modulate different clones harboring different mutations. And for example, if the patient relapse with cysteine 481 mutations, we might be confident because pirtobrutinib is likely to be active in this patient. Instead, if the patient harbor a threonine 474 mutations, pirtobrutinib might be less active in this subset of patients. And another important information that none of the patients who relapse after time-limited therapy with ibrutinib plus venetoclax or venetoclax plus obinutuzumab relapse with a BTK or a BCL2 mutation. So, so this is an extremely important notion that also patient with a high risk disease at higher risk to acquire BTK mutations, if they are treated with time-limited therapy, we are able to decrease the risk to develop mutations, and so and likely to allow a better outcome with further lines of therapy. In the future, we will also deal with new drugs. There are 3 drugs which are called BTK degraders. This one is from the Beijing. Which act in different way from inhibitors, because the degrader is a bivalent molecule which is able to bind the BTK, the target protein, in this case BTK, but also the E3 ligase, E3 ligase cerebron, which led to the polyubiquitination of the target of the BTK mutation, leading to the degradation of the protein. This molecule has been explored in the phase 1 Cadence 101 trials. This is a basket trial in B-cell malignancies, and the results are highly important. 49 patients enrolling, very heavily pretreated patient, 20, including 76% of double refractory patient and 22% of triple refractory patient. That is, patient who relapse even after a non-covalent BTK mutation. So a patient with a very dismal outcome. After a median follow-up of only 4.6 months, 82% are still on treatment. Only 1 dose-limiting toxicity reported, which was a grade 3 maculopapular rash, which resolved with the discontinuation of the drug and the use of steroids. 3 patients died, all 3 due to infections. So suggesting that again the drug is very well tolerated. As you can see, very low number of grade 3 adverse event, even if we are dealing with a heavily treated populations. In the study, there was only an increase of amylase and lipase. This was only a laboratory findings without symptoms of pancreatitis, and again it resolved in a couple of weeks. And of interest, in the study, no cases of atrial fibrillation or grade 3 hypertension has been reported so far. And as you can see in this swimmer plot, the overall response rate is high, and it is independent from, it is similar in double refractory patient or in patient with TP53 abnormalities or complex karyotypes, and the drug is active in patient without BTK mutations, and but also in patient with the active site Cysteine-481 and the gatekeeper mutation, because this drug does not lead the inhibition of the protein, but instead it drives the degradation of the whole protein. So it acts regardless, independent from BTK mutations. There are other 2 drugs under investigation from Nurix, the NX-5948, and which is similar to the CDAC, we're favoring the degradation of BTK, and the NX-2127, which also have an immunomodulatory effect similar to lenalidomides, leading to the degradation of Ikaros and Aiolos in T cells. And again, this drug explored in the phase 1 basket, in this phase 1 basket trial. The drugs is active in different kind of B-cell malignancies and very well tolerated. So we need more information in the next months. For further lines of therapy, other available drugs are the group of CAR T cells. Liso-cells has been approved by FDA, and there is also the group of bispecific antibody, which are a group of drugs, as you know, are very active in indolent and aggressive lymphoma, but which have been explored also in chronic lymphocytic leukemia. Liso-cell, is a CAR T cells, which has, as I said, recently approved by FDA for heavily pretreated relapsed refractory patient. The approval is based on the transient CLL 004 trials. And as you can see, 117 patients were enrolled, including 70 patient double refractory patients. 86 of these patients have a high risk cytogenetics. And in the dose, there was two cohort of patients with different doses of the drugs, and in the dose level 2, the overall response rate for this heavily treated population with this single agent infusion of the drugs, the overall response rate was good, 47%, 40% similar in the overall population and in the double refractory subgroup, including 80% of complete remission. As you can see, there are some patients who were able to reach the undetectable measurable residual disease, about 60% of the patient, and these patients experience a sustained remissions. So, which has not been reached for patient in complete remission and undetectable MRD, but it was lower, about 26.9 months in patient with a partial remission, but again an undetectable MRD. Treatment were well tolerated. They seem to experience more commonly some specific adverse event related to CAR T cells, such as cytokine release syndromes, 85%, even though the majority were low grade, grade 1 or grade 2, and the same is for neurological adverse events. It seems to be more common than than the use of CAR T cells in patients with low risk non-Hodgkin lymphoma. The other study that I want to discuss with you is the CLL-1 trial, which explored the use of epcoritamab, a subcutaneous bispecific antibody, which has recently been approved by FDA for diffuse large B-cell lymphoma or high-grade B-cell lymphoma after more than 2 lines of therapy. Some patients have been treated with epcoritamab in these trials. Again, a very heavily pretreated population. The median number of previous studies was 4, including 4% of patients who already received CAR T cells. After, with epcoritamab, 62% were able to reach a response, including 33% of complete remission, and also the number are low but are encouraging. 75 of assessed patients were able to achieve an undetectable MRD status. So, suggesting that the activity of these important drugs in this heavily pretreated population, and maybe in patients also who were not a candidate for CAR T cells. Regarding epcoritamab specific adverse event, you can see that some patients can develop cytokine release syndromes. The occurrence of CRS is predictable, as the most patients develop CRS when they receive the first full dose of the drug, that is cycle 1, day 15, and then in some sequential infusions, the rate of CRS is lower, but an important information that the majority of all the cases resolve the CRS with the use of tocilizumab or dexamethasone. And also about 13% of the patient develop neurological syndromes, that is ICANS, and only one patient developed and experienced a tumor lysis syndrome. Again, reinforcing the notion that epcoritamab is highly active in this aggressive subset of patients. So, coming to the conclusion of my talk, high-risk category includes patients with TP53 abnormalities, 17p deletion or TP53 mutations, better if assessed by NGS by next-generation sequencing, but also karyotype, complex karyotype assessed by stimulated karyotype with CpG plus interleukin-2, and likely we should include also patients with BTK mutations. The first-line setting in CLL can determine the treatment options, and a patient focus should be utilized when we have to identify the best first-line treatment for the patient. We know there are a variety of different therapy available for relapsed refractory CLL. However, not all options are effective, and the first line influence the further line of therapy. Likely the field is growing with the specific antibody, BTK degraders, other under investigational drugs, and with the use of CAR T cells that allow to address unmet need and gives new hopes to our patients. This was my slide, my last slide, and I'll be glad to answer your questions.
Thank you very much, Dr. Visentin, for this excellent talk, and also for being really on time. I really appreciate it. Now it's time for the discussion, and I will check if we have some questions. Yes, we do have some questions. So the first one, I think, is regarding a specific scenario. How do you think relapsed patients with CLL should be treated if he has coronary artery disease and arterial hypertension, and in the first line he received venetoclax already?
Mm-hmm. Okay, in my current practice, we do not exclude this patient from receiving a covalent BTK inhibitors. Before starting treatment, we did electrocardiogram, we did heart ultrasounds, we do cardiological assessment in order to and we ask the cardiologist to estimate the risk, the general risk for this kind of the patient. But we opt for the use of second generation BTK inhibitors for these patients because the trials demonstrated the safety of this drug also in patients with a cardiological disease, cardiological comorbidities. So, and in the majority of cases, we can use this drug without any problems. In the next future, when maybe pirtobrutinib might be available as a second line of therapy, it might be hard to which drug to use if using a covalent or a non-covalent BTK inhibitor, because one of the best features of pirtobrutinib is the safety profile. It is a very well tolerated drug.
Mm-hmm. Thank you very much. The second question, what clinical and laboratory signs can be used to suspect the development of resistance to BTK inhibitors in a patient?
At this point, we don't have any marker for the assessment apart from the mutation. From this retrospective study, we know that also responding patient can develop the mutation, and the development of a mutation can precede the clinical relapse about 8 to 10 months before. So even if we are able to identify a mutation in any phase of the disease, we should not stop the treatment. We have to await for the clinical progression of the patient. The other issue is about the way which technique should we use for the assessment of mutations, because different small retrospective study use different techniques. And of course, the higher the sensitivity of the technique was used, the higher the rate of mutation were identified. Sometimes there are more clones together and with different variant allele frequencies. So there are many points of discussion. So it's not clear which technique to use and which should be the threshold of sensibility of these techniques.
Mm-hmm. I understand. And we have one more question, and I think you already mentioned about it. So, if you can just briefly rediscuss, if you are facing some treatment discontinuation in one of your patients, and the patient is showing signs of relapse, what would be your approach?
Yes, so if the patient discontinued the drug, for example, the BTK inhibitor due to adverse event, I try to switch, maintaining the same class and use another BTK inhibitor. For example, if the patient discontinued treatment with ibrutinib, I will move to a second generation BTK inhibitors. If the patient discontinue acalabrutinib due to an adverse event, I would move to zanubrutinib because there is just some because it is another very well tolerated drugs. But again, in the future, when pirtobrutinib might be available, I'm not sure if using again another second generation BTK inhibitor or pirtobrutinib.
Okay. And still in this topic, so if you have a fixed direction versus continuous treatment, what would you recommend between retreatment versus the changing of class of the drug?
Can you?
Yes, so the question is in a topic of fixed durations versus continuous treatment,
yes.
What would you recommend between the retreatment versus changing class of the drug?
Okay. As a general things, I would, if a patient is relapsing after a time-limited therapy, if the duration of remission is enough, we can think about retreatment or using the same time-limited, similar time-limited therapy. Instead, if the patient relapses early, I would opt for a continuous treatment. But this short or long period of time is not has not been defined. The guidelines suggest 36 months, which was used for when we use the chemoimmunotherapy for chronic lymphocytic leukemia, but there is no prospective data with the use of time-limited targeted agents. So the duration might be longer or shorter depending on several aspects.
Okay. Let me check. So there is one question related to the immunochemotherapy regime. Is there any group of patients for whom you would still recommend the use of immunotherapeutic regimes at the first relapse?
At the first relapse,
yes.
At the first, so as second-line therapy, none of the patients. I do not currently use chemoimmunotherapy, neither in the front line or in the relapse settings. Also, the ESMO guidelines allow for the use of frontline chemoimmunotherapy, fludarabine, cyclophosphamide, and rituximab for patient with for a very low risk patient, that is patient with mutated for the immunoglobulins without TP53 abnormalities, without complex karyotype. And they also wrote that FCR can be used if targeted agents are not reimbursed in that country. But we have to keep in mind that in a large study by Eric about the risk of developing second primary malignancy in patients with CLLs, the only risk factor associated with the risk to develop myeloid malignancies, myelodysplastic syndrome, or acute myeloid leukemia was the previous treatment with fludarabine-based therapy. So again, we have very long, some patients can experience very long remissions, but some of them can also develop a myeloid malignancy because I treated them with fludarabine-based therapy. So the risk might be balanced.
Okay, thank you very much. I think you really explained everything very well.